Welcome to The Explainer. Today, we're diving into one of the most important topics for your nursing career, how to handle critical complications during labor and delivery. So here's our game plan. We're going to build a mental framework that you can actually use in clinicals and on the floor. We'll start with the basics of normal labor. Then we'll get into what happens when things go off track. And finally, we'll cover those true, heart-pounding emergencies where your actions really matter. You know, before you can ever hope to spot what's abnormal, you have to be an absolute expert in what's normal. So let's start there. Let's establish your baseline role when a patient first comes in. All right, picture it. You're in the room and your patient looks at you and says, "I think my water just broke." This isn't just a textbook question. This is real life and it will be on your exams. What is the very first thing you do? Your number one priority? The answer is you get that fetal heart rate, and you get it immediately. Why? Because you are ruling out a prolapsed umbilical cord. See, when that cushion of water is gone, the cord can slip down and get compressed by the baby's head. That's the baby's oxygen supply getting cut off. You're looking for sudden bradycardia or scary-looking variable decelerations. Those are your red flags. So this really frames your first few minutes with any patient. It's all about stability, for mom and for baby. But look at that critical action at the bottom. This is huge. If a patient comes in with active bleeding, you absolutely do not do a vaginal exam. Painless bleeding could be a placenta previa. Painful bleeding could be an abruption. Either way, an exam could cause a massive hemorrhage. Safety first, always. Okay, so we've got our stable baseline. Everyone's doing great. But what happens when the whole process just stalls? This is the big umbrella term for when labor just isn't progressing. You'll hear it called failure to progress. And as the nurse, you're the detective. You start asking, why? Is it a problem with the powers? You know, weak or uncoordinated contractions? That's what we call hypotonic dystocia. Or is it something with the baby, the pelvis, or even the patient's anxiety? Your assessments are what guide the entire team.
Now, for a very specific and very urgent type of dysfunctional labor, the turtle's sign. It's a name you'll never forget once you see it. The baby's head is born, and then it pulls right back against the perineum, like a turtle pulling its head into its shell. That is your classic screaming sign that the baby's shoulder is stuck on the pubic bone. This is a full-blown emergency.
And this is where you become a critical player. You are not just a spectator. You yell for help, and then you immediately get that mom into the McRoberts maneuver, pulling her knees way back to open up her pelvis. Then comes suprapubic pressure right above the pubic bone. And please, burn this into your brain. You never, ever push on the top of the fundus. It will only make the impaction worse and can cause serious harm. Okay, let's switch gears and talk about some of the powerful tools in your toolkit. We're talking about medications. As the nurse, you're the one giving these meds and managing them, and they can completely change the course of a labor.
So, when labor starts way too early, our main goal is often just to buy a little time. Tocolytics are the drugs we use to try and stop contractions. And honestly, even just 48 hours can be a game changer. It gives us a window to give corticosteroids to help the baby's lungs mature, which can make a world of difference.
This little table, this is pure gold for your exams. From magnesium sulfate, your whole world is about watching for toxicity. Are her reflexes disappearing? Is her respiratory rate dropping? You better have calcium gluconate right there at the bedside just in case. For nifedipine, it's all about blood pressure. And with terbutaline, that black box warning is no joke. It's for short-term rescue use only, and you have to check that apical pulse before every single dose.
Now, on the flip side of stopping labor, sometimes we've got to get it going. Oxytocin is the heavy hitter here, but it is a high-alert medication. It demands continuous fetal monitoring. And before we even start oxytocin, we might use something like misoprostol or Cytotec to help soften and ripen the cervix to get it ready.
And this, right here, is a non-negotiable safety rule. If your patient is attempting a TOLAC, a trial of labor after a C-section, misoprostol is completely off the table. It is an absolute contraindication. Why? Because it significantly increases the risk that her old uterine scar could rupture. This is a massive patient safety point. All right, take a deep breath. We are now heading into the red alert section. These are the true obstetric emergencies. The situations where your quick thinking and immediate actions can literally save a life. We mentioned this at the very beginning, but now we're going to focus on it. A prolapsed cord is a time-critical, terrifying event. The baby's lifeline slips out ahead of the baby, and with every single contraction, it gets squeezed, cutting off oxygen. You are in a race against the clock.
Your job in this moment is singular: get the pressure off that cord. You hit the call bell, you scream for help, and then you put a sterile glove on and you physically push the baby's head up and off that cord. And listen to me, you do not take your hand out. You will ride on that gurney to the OR, holding that pressure until the doctor tells you the baby is out. Your hand is literally keeping that baby oxygenated.
So as you can see, a lot of these complications, from a stalled labor to a true emergency, end up in the operating room. So let's talk about your role there, specifically in the very high-stakes situation of a VBAC.
Now, a successful VBAC is a wonderful thing. It often means a faster recovery for mom. But the TOLAC, that trial of labor, carries that small but incredibly serious risk of uterine rupture. This is not a patient you can check on every hour. This is a patient who needs your constant vigilance and continuous monitoring.
And here it is. This might be the most important thing you learned today. Do not wait for the patient to scream in pain. The most reliable and often the very first sign of a uterine rupture happens on the fetal monitor. You see recurrent late decelerations or a sudden deep bradycardia. That's your signal. Your eyes have to be glued to that strip.
So, when those alarms start blaring and the room suddenly fills up with people, what is it that makes a nurse the calm in the center of that storm? It's not about being fearless. It's about being prepared. It's having a clear mental framework just like the one we've talked through today. It's knowing your baseline, knowing how to spot trouble, and knowing your critical first moves without even having to think. That's what turns chaos into confident, life-saving action.